Okay. Good morning, everyone. I think we'll get started. So today we have one of our own faculty members, Dr. Mike Grunebaum. Before introducing Mike, a couple of quick updates. There are no department announcements, but updates on grand rounds. Next week, there's no grand rounds because of the ACNP conference. The following week, there'll be the Spitzer lecture by Jerome Wakefield from NYU. And then we have no grand rounds again until after the new year. Okay, so today's speaker, Dr. Mike Grunebaum, grew up in Cambridge, Massachusetts, and then attended college at Harvard, majoring in English. He then has a really interesting background. He then, after college, he worked for a couple newspapers for 2 years, including the Lowell Sun and the Lawrence Eagle Tribune. And while doing that, he won a community service award for a series of stories that he did on lake pollution that led to a building moratorium because of environmental toxins. Yeah, which I think would be remarkable for anyone, but certainly even more so for someone who's fresh out of college. He then went back and did his pre-med courses and then went on to do medical school also at Harvard. After finishing medical school, he did his psychiatry training at Payne Whitney. He then came to Columbia for a public psychiatry fellowship, where he was working in homeless shelters in the New York City area. And while doing that, under the mentorship of Mike Olfson, started to do some research on medication adherence. And it seems like that whetted his appetite for research. He then got further involved and joined John Mann's group, the Mind Research Clinic, in 2000. And since then has been very active in research with NIMH funding, NARSAD funding, conducting multiple RCTs. And so today we're going to hear about his work on ketamine, clinical trials for suicidal ideation, and next steps. So thank you so much, Mike.
So good morning, and thank you, Jonathan, for the nice introduction. It's an honor to have the opportunity to speak here today. The title of my talk is Listening to Ketamine, Clinical Trials for Suicidal Ideation and Next Steps. And I chose the title because, first of all, let me say the funding for the research that I'll be discussing was NIMH and NARSAD, and I don't have any financial disclosures. So I chose the title for today because the current level of interest in ketamine reminds me of another drug that was considered a breakthrough for depression treatment, which of course was Prozac, which was approved by the FDA in '87 and spawned a whole raft of books, including the iconic bestseller by Peter Kramer, Listening to Prozac. And a few years later, spawned another raft of Prozac backlash type books, which I think we all remember probably. And hopefully that won't happen with ketamine. But I think today's talk is also timely in that there was a story in the Sunday Times about suicide and querying whether ketamine, I don't know if you can read this, but whether ketamine might be the solution. And also timely because Columbia's own ketamine treatment service recently opened its doors only a few weeks ago at the 51st Street location. So I have three goals of my talk today, and it's from my clinical psychopharmacology research perspective. The first is the reasons for the current interest in ketamine, in psychiatric use of ketamine. The second is to discuss the clinical trials I was involved with using ketamine for suicidal depression in particular, and thirdly, possible next steps. And I'll give you the bottom line of my talk right now, which is from my perspective from having overseen about 100 ketamine infusions over the past 5 or 6 years. So first, ketamine does really seem to have some remarkable awakenings-like effects for some patients when they have a robust response. But I don't think it's, quote, the solution, as was, I think, a little provocatively hinted at in the New York Times article title. And we still know very little about the safety and efficacy of truly long-term use, which is key because depression typically tends to be a long-term condition. I truly hope that understanding ketamine's mechanism will lead to new and safer drugs, as I think we all do. And I think it may be potentially a useful intervention in the emergency department or inpatient units, particularly for suicidal or treatment-resistant depression, and of course with appropriate consent and precautions. And certainly more research needs to be done in those areas. So what is ketamine? It's a drug that was synthesized in 1962 as an anesthetic agent by the Parke-Davis Pharmaceutical Company. It was approved by the FDA in 1970. It causes dissociative effects, which means it makes people feel very weird and spacey. It's still used in anesthesia, especially in children and animals, and it's used frequently in emergency departments in children for procedures. It's used in chronic pain clinics. As distinct from the current antidepressants that we have available, which act mainly on brain monoamine neurotransmitters like serotonin and norepinephrine, ketamine inhibits the glutamate NMDA receptor, so it appears to have a unique mechanism, at least partially. But it does also affect other receptors, including dopamine and opioid receptors. Ketamine is also a drug of abuse, called Special K sometimes. I won't be focusing on that particular topic because it's not my area of expertise and would require a separate talk. But we do know that chronic heavy use of ketamine, such as in addiction, can cause serious injury to both brain and bladder. And a key point is that we still don't know the threshold for that injury. So ketamine for depression is generally given in the standard dose would be 0.5 milligrams per kilogram intravenously infused over 40 minutes. An anesthesia dose would be 5 to 25 times higher. When it has an antidepressant effect, it typically occurs within a few hours. It can be given by other routes, though, and appears to be effective intranasally, intramuscular, etc. It has a very short half-life of about 2.5 hours, but the antidepressant effect lasts about a week, which is one reason, or a primary reason, for all the excitement, because the antidepressant effect appears to be distinct from the acute high, which lasts only about, with a 40-minute infusion, people usually clear up within about 15 or 20 minutes after. So it's quite transient. A leading theory of ketamine's antidepressant mechanism of action is that, and this is from preclinical or animal studies, that it promotes rapid increase in synaptic plasticity with formation of new dendritic spine synapses within 24 hours. And this occurs via glutamate pathways with decrease of NMDA, an increase of AMPA, 2 glutamate receptor subtypes, the activity of those. And also along with increases in BDNF and brain-derived neurotrophic factor, which is a protein involved in neuronal health, and also increases in GABA, a inhibitory brain neurotransmitter. Finally, a pharmaceutical company, Janssen, has an intranasal formulation, S-ketamine, which is the S enantiomer of racemic ketamine, which comes in a S and R form, which is on a FDA fast track. They submitted a new drug application in September. I don't know exactly how fast the fast track is, but perhaps it could be on the market in the next year or so. And the S-ketamine enantiomer is about twice as potent as the R enantiomer, which is, I think, why they chose that. So actually, psychiatric use of ketamine has been known for many decades. This article in Psychosomatics from 1973 describes a study done in southern Iran, mostly in anxiety disorders. I hope you can see the type here is probably small, but anxiety, dissociative reaction, phobic, obsessive, compulsive, conversion, hysterical, hypochondriasis, depressive, etc. So it seems to be mostly anxiety disorders with some depression. They excluded psychoses. They gave a total of 100 patients a dose pretty much exactly like what's used in most depression studies, intravenously, and found that 95 of the 100 had facilitation of their psychotherapy and symptom relief. And an even further back study of a drug that's similar to ketamine in that at high doses it inhibits NMDA glutamate receptors, cycloserine, which is an antibiotic used for tuberculosis. This study in Comprehensive Psychiatry in 1961 describes a trial where they gave a dose that could inhibit NMDA receptors of cycloserine to 30 TB patients with mainly neurotic disorders, probably a mix of depression and anxiety, though it wasn't specified, and 48% had relief from depression. So similar effects to current studies, I think. So in the 15 years from 1999 to 2014, antidepressant use increased 65% in the United States. It's now, antidepressants are the third most prescribed drug class in the US after analgesics and statins. 13% of people in the US over 12 years of age are taking an antidepressant, and 25% have been taking one for 10 years or more, and this is data from the CDC. So despite that, treatment resistance remains a problem. About 30 to 50% of patients have what's called treatment-resistant depression, usually defined as a failure to have an adequate response to 2 or 3 trials, adequate trials of an antidepressant. And we still know little about phenomena like Prozac poop out, what it's sometimes called when there's a loss of a previously effective antidepressant response, or the technical term being tachyphylaxis. And we also don't know much about the effects of antidepressant use over many years. So despite the increase in antidepressant use, suicide rates have risen 25% and continue to rise. And the increase in suicides have been all across the country. And this increase, along with the epidemic of deaths from opioids are what has driven the third year in a row of declines in the United States life expectancy, which was reported on the front page of the Wall Street Journal only last week. And this was referred to as a wake-up call by the director of the CDC. So sadly, along with this, drug companies seem to be losing interest in psychiatric drug research. This article in 2016 from The Guardian reports that pharmaceutical companies have cut back 70% of their psychiatric medicine research in the past 10 years. And contributors to this are probably the large placebo effects that are known to occur in antidepressant trials, which results in failed trials and which are very costly for drug companies, and hence there's been, as this article described, nothing particularly novel in a long time. And hopefully that may be turning around also with the interest in ketamine, given that it has opened a door to possibly a new mechanism for antidepressant medication treatment. So interest in ketamine was renewed when trials at Yale in 2000 and NIMH in 2006 showed ketamine's rapid antidepressant effect even in treatment-resistant depression. When we began our trials in my division, very few local clinics offered ketamine off-label for depression. The former NIMH director, Tom Insel, wrote a blog post in which he said that medication development for mental disorders has hit a wall, and he described ketamine as possibly the most important breakthrough in antidepressant treatment in decades. And he highlighted 3 findings: its rapid effect within hours, its benefit for treatment-resistant depression, and that it reduces suicidal thoughts. And he also commented importantly that we don't know yet if repeated injections will be safe and effective, and that is pretty much still true. So currently, ketamine clinics, or over the past few years, have spread across the country. This is just a small handful of things I found on the internet. So with this, we can see that the interest level seems to be great and even growing. Now I'd like to transition to the clinical trial work that we did in the Mind division, the Molecular Imaging and Neuropathology division where I work, which was primarily a clinical trial, RCT, randomized clinical trial of ketamine for suicidal major depressive disorder. And a little background first. There's very little data still to guide medication management for suicidal patients. And suicidal patients have historically been excluded from randomized clinical trials. But suicidality is urgent, and antidepressants take weeks generally to relieve depression and suicidal ideation. And also, studies have shown that depression does predict suicide attempts, at least partly via its effect on suicidal ideation. There were some early clinical studies of ketamine for suicidal thoughts, but they had some limitations, including measurement of suicidal thoughts by just one question on a depression scale, for example, like item 3 of the Hamilton, or there were no control condition, an open study, or perhaps a saline control, which might be very easy for patients to distinguish from the active treatment, or they only had patients with very mild levels of suicidal thoughts, or with a mixture of diagnoses. We designed our trials to enroll adults with major depressive disorder who had depression Hamilton rating score of at least 16, which would be considered moderate, or moderate level, and a Beck scale for suicidal ideation score of greater than or equal to 4. The scale for suicidal ideation, or SSI, is a gold standard rating scale, 19-item rating scale for suicidal thoughts developed by Aaron Beck at UPenn. And a score greater than or equal to 4 has been considered clinically significant in a number of studies. So we wanted to specifically enroll patients with a clinically significant degree of suicidal thoughts. Patients had to be medically stable. We excluded psychosis and substance dependence in the past 6 months, and also ketamine abuse or dependence. And patients were allowed to continue their current psychiatric medications. They were randomized to either ketamine at the standard dose or midazolam, which as a control condition, which is a short-acting benzodiazepine anesthetic with a similar half-life to ketamine, the logic being that it has some psychoactive effects, so would be a better control condition than saline, for example. There's no ideal control for ketamine given its unique dissociative effects, but midazolam has been used in other studies. And we required that patients be inpatient, at least for the infusion phase of the study, given the requirement that they be suicidal, have suicidal ideation, and for safety reasons, really. The primary outcome was scale for suicidal ideation score at 24 hours after the infusion, or day 1. And we also defined a response category of remission for day 1, whereby to be a remitter, you had to have at least a 50% drop in your suicidal ideation score, but also the score had to be below 4, meaning that you wouldn't be eligible to enter the trial. And the reason for that was so that people who were non-remitters could have the opportunity to get ketamine if they had received the control drug. Response was defined as usual as at least a 50% drop, but without the score of 4 criteria. And after the day 1 research ratings were completed, we offered patients up to 6 months of medication management treatment, and the first 6 weeks we continued to do depression and suicidal ideation research assessments. So the patients were enrolled between 2012 and 2016. The total sample size and total sample analyzed was 80 patients, which was 10 more than our target sample had been. 54% were taking an antidepressant at baseline. The mean age was 40, with a mean Hamilton score of 22, which is moderate to severely depressed. And the mean scale for suicidal ideation score was 15, which is also in the moderate range. The sample was 60% female, and 70% had a prior psychiatric hospitalization, 50% almost a past suicide attempt, and the median age at onset of the first major depressive episode in this sample was 16, and the current major depressive episode duration was 56 weeks. And finally, the average lifetime medication history in the sample was past history of 4 antidepressants, 2 antidepressant classes, and 61% had received a second-generation antipsychotic. So overall, I think you can appreciate it was a sample with a fairly severe level of illness and also a fairly significant degree of suicidal ideation and past suicidal behavior or attempts. Fortunately, the randomization appeared to work relatively well. Baseline characteristics were mostly well balanced between groups. There was one exception that I'll get to shortly. So the main paper was published in the American Journal in April, and the main result is that ketamine appeared to have an advantage at day 1 of about 5 points on the scale for suicidal ideation in terms of reduction from baseline, an advantage over the control condition, and it was highly statistically significant. And the Cohen's d effect size was 0.75, which is a solidly medium effect size. One baseline characteristic, notably, one notable baseline characteristic that was not balanced between the two groups was borderline personality disorder diagnosis, but we ran a separate model adjusting for that, and it had very little effect on the results. The categorical outcome of whether you were a responder or not at day 1 corroborated the overall main finding in that response rate was about 55% versus with ketamine versus 30% with midazolam, and that was statistically significant with a number needed to treat of 4, which means that you would need to treat 4 patients with ketamine to have 1 more responder than you would have with midazolam. That's a metric that's used more commonly, I think, in the United Kingdom, where they have universal health care and have to decide which treatments merit coverage. And a number needed to treat of 4 is considered good. You want a small number, and that's considered pretty small. 35 of the 40 midazolam randomized patients were non-remitters at day 1, and all opted to receive the open ketamine infusion. And just to take you through the plot quickly, the red line is the group that was randomized to ketamine, and the green is midazolam. So you can see they did improve a bit at 230 minutes, about 4 hours after the infusion, but then started to worsen at day 1 and worsened a little more at the baseline rating before their open ketamine infusion, after which 24 hours after which they improved, again, quite similarly to the group that had initially gotten ketamine. And this is the 6-week observational follow-up. And keep in mind there's no control group here, but the benefit appeared to be relatively well maintained for 6 weeks. And this is in the setting of immediately either starting patients on an antidepressant medication or optimizing their current medications in the case of the roughly half the sample that were already on medications. There were a few patients, to be exact, 9 patients who received midazolam who had increased suicidal thoughts at day 1, and 2 patients who had received ketamine. And I should note that occasionally we see kind of a delayed response to ketamine. One illustrative example, I think, is in our bipolar pilot trial, which I'll mention in a little bit. One patient felt significantly worse, I would say, in the afternoon after the infusion, and had increased suicidal ideation, but at day 1 was a complete remitter and was virtually euthymic with no suicidal thoughts. Some patients we would respond or remit as long as 48 or 72 hours after. So in a small percentage of people, there seems to be kind of a delayed effect. So the important question, though, is whether our results are clinically meaningful, and I think there's at least some evidence to suggest that they are. Clinical trials in the past several decades, based on work by Michael Thays at UPenn, show an average three-point advantage of antidepressant over placebo on typical depression measures like the Hamilton. And in the UK, the National Institute on Health and Care Excellence considers a Cohen's d effect size of 0.5 or a 3-point between treatment group difference on the Hamilton clinically significant. So our results exceed those thresholds, and I think that at least suggests that they're clinically meaningful. On the Hamilton Depression Scale, though there was a weaker effect, which was a bit of a surprise. You can see the graph looks pretty similar, but it was not statistically significant. But the Hamilton scale is not really designed for a very brief time period like 24 hours, whereas the Profile of Mood States scale, which we also assessed, or the POMS, is considered more suited to a short time frame like 24 hours. And there we did see a statistically significant advantage on the depression subscale as well as the fatigue subscale and the total score. And the fatigue subscale finding, I think, is interesting in that patients subjectively reported that they felt more energetic and motivated the day after if they had responded to the ketamine. We did a mediation analysis which showed that POMS depression only mediated about 34% of the ketamine effect on suicidal thoughts, which is notable because it suggests that ketamine's effects on overall depression versus on suicidal ideation are at least partly independent. The main side effects of ketamine are the dissociative or spacey side effects that people feel during the infusion, where they can feel sort of out of body or like they're floating, or their body feels larger or numb, or they say that was really, really weird, or sometimes they would feel like they couldn't talk, and in some cases it was an unpleasant experience. I would say, maybe 15% it's kind of dysphoric and unpleasant. Maybe a large chunk in the middle, it's just kind of strange and weird, and another 15% at the other end of the bell curve feel really euphoric and say, wow, that was great, thanks, doc, for that high. So at least that was my observations. You can see that immediately after the infusion, the ketamine group has a lot of dissociation, but there's very little in the midazolam group, which makes you a little concerned about how intact the double blind was. But I will say that we did assess the blind, and the correct guessing of the randomized drug among both raters and patients was not statistically significant. So the blind did appear to be intact. And you can also see that the dissociative effects are gone a few hours after. I would say even faster than that, really more like half an hour to an hour. They're mostly gone. Some other safety results. There's a slight blood pressure elevation with ketamine, about 13 to 15 points, which goes back to baseline in about 5 minutes after the infusion. We assessed at 3 and 6 months and didn't see any signs of ketamine abuse. 5 participants in the study went on to get ketamine off-label in local clinics. During the time of the study, there were 4 suicide attempts, fortunately without serious medical injury, and 3 psychiatric admissions for increased suicidal thoughts. We also did cognitive testing using a battery of standard tests at baseline and at 24 hours after the infusion, and saw overall improvement in the ketamine group compared to midazolam. And again, this corroborates patients' subjective report in that patients who responded tended to feel like their thinking was clearer, they could focus better, they would be able to take a book out of the PI 5 South library and start to read again. The cognitive improvement appeared to be in reaction time. They were thinking faster. In the Stroop interference test, which measures executive function, and in delayed memory recall on the Buschke test. We did a range of exploratory biomarker assays, which unfortunately didn't yield a whole lot in terms of robust results. These included saliva cortisol awakening to look at stress response, brain-derived neurotrophic factor in plasma and serum, and a genetic polymorphism, and ketamine and metabolites, and we're finalizing analyses of one of the metabolites, hydroxynorketamine, which has received a lot of attention in the literature based on a preclinical study which suggested that the R enantiomer had NMDA-independent antidepressant effects. But again, that was a preclinical animal study. So there are limitations of our study, including that we studied suicidal ideation, whereas ideally one would study suicide attempts or even suicide, but that requires really huge samples of hundreds or thousands. So suicidal ideation is a feasible proxy. The borderline personality disorder was not evenly distributed between the groups, but it didn't appear to affect the results when we controlled for it. And I mentioned the lack of control group in the observational follow-up ratings and the difference in dissociative effects. So now I'd like to transition to talking about some other preliminary work on ketamine. First, our pilot bipolar suicidal depression trial with 16 subjects. We found, again, an advantage for ketamine of about 6 points and a Cohen's d of 0.98, which is a little larger than with the unipolar trial, but it wasn't statistically significant, although a trend possibly. And hopefully a larger, more definitive trial could be done, which would hopefully have greater power to detect a statistically significant effect. We also did some pilot structural and functional MRI scans in 5 bipolar, suicidal, depressed patients before and after ketamine infusion. And I'd like to first describe some structural results using diffusion tensor imaging, which measures uses the diffusion of water molecules to measure white matter structure and integrity, and in particular, the measure of fractional anisotropy, or FA, is considered an indicator of the integrity or health of white matter. And usually you want to see that increase. That would be considered typically a good thing. We saw a paradoxical 15% decrease in FA, which correlated with decreased suicidal thoughts. But if you remember, I mentioned that one of the leading theories for ketamine's mechanism of therapeutic action in depression is increased synaptic density, which actually has been shown to decrease FA in some studies. So we speculate that perhaps that might be the explanation or part of what's happening with this result. We did also some pilot analyses of resting state functional connectivity, and the region of interest analysis showed that decreased suicidal thoughts correlated with a bilateral decrease in resting state functional connectivity between the anterior hippocampus and the ventromedial prefrontal cortex, and also between the posterior hippocampus and posterior cingulate cortex. And these held up even adjusting for change in depression score. And a whole brain analysis confirmed the region of interest results. So a possible model explaining this is that we speculate that ketamine may be causing a decoupling of the hippocampus, which is an important brain region for depression, and the ketamine may be causing a decoupling of the hippocampus with midline anterior and posterior default mode network components. And the default mode network is a large network in the brain that oversimplifyingly is thought to be associated with the brain not being at rest or mind wandering or not focused on a task or in an introspective state, but also thought possibly to be associated with the ability to imagine or what others are thinking, the theory of mind, so-called, and also the ability to understand narrative or story. So it's very complex and not my particular expertise, but those are some important aspects of the default mode network. And elevated default mode network connectivity has been associated in studies with depressive rumination. And depressive rumination has been shown to be a risk factor for suicidal thoughts and behavior. And so we speculate whether ketamine may be reducing the connectivity, which may help to modulate hyperactivity of limbic structures, which has been seen as possibly a general finding in mood disorders. And I would also mention that Jonathan Posner et al. From our faculty amazing article in 2013 showed that a decrease in default mode network connectivity after duloxetine treatment. So our results may be at least partly consistent with that. And I'd also just like to quickly thank our brain imaging lab in my division, Jeff Miller, its director, Spiro Pontezatos, Harry Ruben Falcone, and Dongrong Xu for great amount of help with this work. I'd also like to mention Matthew Milak in our division's impressive study published in Molecular Psychiatry in 2016, where he gave depressed patients a ketamine infusion while they were in the MRI scanner and performed MR spectroscopy using this voxel in the, I believe, subgenual prefrontal cortex, which is thought to be a key region for depression pathophysiology. And he reported 40% increases in both GABA and GLIX, which is a combined measure of glutamine and glutamate. There's a new PET scan tracer, UCBJ, which is specific for a synaptic vesicle glycoprotein, and so can provide a measure of synaptic density in vivo in the human brain. And our division is planning pilot scans pre and post ketamine, which could potentially shed light on this rapid synaptogenesis theory of ketamine's action. And then another important study to mention, I think, is this one from a Stanford group, which includes Carolyn Rodriguez, who was a resident here and faculty member until recently, where patients with depression were randomized to receiving either a placebo or naltrexone, which is an opiate blocker, before a ketamine infusion, and they found in a very small sample, but pretty robust blockade of about 2/3 of the ketamine antidepressant effect. So the green is the placebo group with a nice response, and the naltrexone group, you see about only 1/3 of the response. So in our time of opioid epidemic, clearly this is an area for further research and understanding. So next steps, I would hope to see a definitive trial in bipolar depression, study of the utility in the emergency department or inpatient units for rapid treatment of suicidal patients. We desperately need safety and efficacy data on long-term use and greater understanding of ketamine's therapeutic mechanism, including an understanding of how key the opioid effect is in that. I'd like to mention another thought, which is that we need new treatments in depression, at least in part because depression is so heterogeneous. And I just wanted to highlight an amazing recent study, I think the largest genome-wide association study to date in depression from the Major Depressive Disorder Group in the Psychiatric Genomics Consortium, with over 130,000 depression cases compared to over 340,000 controls. And just a few choice quotes from the article: that the findings imply a continuous measure of risk. All humans carry lesser or greater numbers of genetic risk. And lastly, that major depression is not a discrete entity at any level of analysis, which I think is important to bear in mind. From a kind of metaphorical level, I think this is sort of what we're dealing with. If this is the Mississippi watershed, and if the blue line is the Mississippi, and all the little lines are all the myriad tributaries, and here's depression and the depression and suicidality phenotypes in the middle. And I think it's sort of a nice image of what we're facing both clinically and in research. And I just want to acknowledge this was based on a very similar image that was shown in a talk in our division probably more than 10 years ago by Joe Terwilliger, who is an eminent statistical geneticist, who showed a very similar picture, making a similar point, which really stuck with me. So in summary, I think ketamine may be a useful addition to treatment of depression, especially in severe cases such as suicidal or treatment-resistant depression. But we need to exercise appropriate caution and monitoring, including medical monitoring, of course, given the effects on blood pressure, and psychiatric monitoring, given that it has some potential for a dysphoric reaction, and informed consent. We certainly need more research, both clinical and mechanistic. And ketamine is still only available now off-label, which means it's not covered by insurance, and that raises issues about who can afford it. But S-ketamine, the Janssen intranasal formulation, may be available pretty soon, and then we will, as clinicians, have to face the question of, do we prescribe it, and for who? So finally, I'd like to acknowledge the large number of people who made invaluable contributions to this work. And first, I'd like to thank my division chief, John Mann, and neuropsychologist John Kelp, who is back there. Hi, John. Who were the first to really bring to my attention the importance of trying to do a randomized clinical trial of ketamine for suicidal thoughts. And I'd like to thank my colleague Matthew Milak, who developed the very first ketamine study in our division. I'd like to thank all my wonderful division colleagues, and particularly the 4 research assistants who worked so hard on all of this research, the wonderful biostatisticians who I had the privilege to work with, Hanga Galfalvi, Tsewei Chu, and Steve Ellis, the lab personnel, Tom Cooper and Ray Sakawa, and ketamine assays, Youngyu Huang and polymorphism genotyping, and the anesthesiology consultant, Vivek Moitra, who is at Presbyterian, who donated his time and really treated our investigator anxiety during all of the infusions. He was always there for a cell phone call. What do we do about this or that blood pressure and so forth? And I'd like to give a big thanks to Manny de la Nuez in the Biological Studies Unit, who contributed and helped us in so many ways. I can't name them all, but one huge one was successfully inserting about 150 IVs, which were essential for this study. I'd like to thank the NISP 5 South Inpatient Unit for taking care of the majority of our patients, and the 4 Center Unit for being a backup, the IRB for tolerating this protocol, and the DSMB members for monitoring the data and safety. And that's it, and so thank you.
So, thank you so much, Mike. That was a really, really lovely talk, and such an important and impactful body of work. So I think we will open it up to questions.
Really interesting work. Am I correct in assuming that you're using this IV because studies have shown, similar studies, randomized controlled, if you use PO, that it's not effective?
Yeah, I mean, first of all, yes, IV has been shown to be the most effective route thus far, and as you know, research is very incremental. Most research studies were using it IV, so we followed suit. I think it would have been premature for us to use a different route for this particular study, since the novel aspect of this study was a rigorous study of the anti-suicidal ideation effect. But there have been a couple studies in Australia at the Black Dog Institute, which I think is named after how Winston Churchill allegedly referred to his depressed moods as the black dog. But they've done some studies of subcutaneous and intramuscular administration of ketamine, and at least the intramuscular studies seem to have maybe not quite as good, but comparable, somewhat comparable results, and obviously that's easier to do. The intranasal data basically looks like it's a little less effective and slightly more side effects, but still seems to be effective and obviously much easier even than intramuscular.
So there is or isn't literature on a PO study that would parallel what you've done?
Yeah, PO, I'm not aware of any reasonably sized PO studies. I think there may be a few small case series, as I recall, or case reports, but I think no really substantial PO trials at this point, to my knowledge.
Thank you for that talk. I'm over here on the right. Sorry. Thanks. I'm just wondering if you can talk a little.
sorry.
Yeah, I know. My voice is coming from a strange place.
Oh, sorry about that.
No, that's okay. I'm wondering if you could talk about the therapeutic techniques, if at all, during the infusion, and if this opens up any kind of ideas for you of using therapy with dissociated states such as psychedelics, MDMA, and future possibilities for treatment of mood disorders.
And are you talking about the psychotherapeutic aspect during the infusion, or just the somatic treatment of depression with these various compounds?
Yeah, I guess I'm wondering if you did any kind of interventions therapeutically during the infusion, or what does the actual treatment look like? Are they kind of just, in an infusion room? And
I understand. Yeah, so it's a great question. In our study, we didn't attempt to do any systematic psychotherapeutic interventions during the infusion. Myself and a research assistant were there the whole time, and mostly to provide reassurance if patient had questions or developed any dysphoria or anxiety, and also for safety reasons, of course, medically. I believe Elias Dakwar, a colleague here, I don't know if he's here today, but may have done some more systematic psychotherapeutic interventions during the infusion in his studies in patients with addictions using ketamine. And in terms of psilocybin and MDMA and those compounds, I definitely not an expert in those yet, and I think it seems to be even much earlier days research-wise with those than with ketamine. So I guess I'm innately somewhat skeptical, maybe to a fault, but so I have some trepidation about that, but if well-designed studies support their benefit, then that would be wonderful, and I guess history will tell.
It looks like in your study, the mean age of the subjects was around 39.
Yeah.
And do you have any take on giving ketamine to people who are old, sick, or cognitively impaired?
Well, I certainly would be hesitant to give ketamine to someone with cognitive impairment, since we know that chronic heavy use clearly causes cognitive damage. So someone who already is fragile in that area, I just would not feel comfortable with that until we have more data. But in terms of older, younger patients, at least, with one or even, as some of the studies have shown, a dozen infusions over a couple months, it really seems to be medically quite safe. That's my impression. So unless someone had very brittle hypertension or serious cardiac disease, since ketamine is sympathomimetic and elevates blood pressure and heart rate, apart from that, I wouldn't have major medical concerns in terms of older population or younger. Yeah.
Hi, yeah, if I understand right, the 80 patients who were recruited and the infusions performed over about 4 years, something like that?
Yeah, about that.
Just thinking of the obvious analogy to opioid prescription and as a pathway to opioid abuse, have you had any feedback from any of the patients who received these infusions about their pursuit of ketamine in less structured settings afterward?
Yeah, we actually assessed that at 3 months and 6 months. We followed up, did follow-up contacts with patients and specifically asked if they had received ketamine subsequent to the study infusion in any other setting. And we basically didn't see any. As I mentioned in an earlier slide, there were 5 patients who sought ketamine treatment in clinics off-label with physicians, and there was really no signal at all for abuse or of that. And we had pretty good, about 80% follow-up on those assessments. So it was pretty reasonable sample, I think.
Yep. Hey, Mike.
Hi, Larry. Oh, no,
I'm
Dave?
over here.
Oh, Dave, sorry. 2 microphones.
So, not to put you on the spot, but I remember at the time when you talked about this study, and I was really anxious about it because you were going to admit so many suicidal individuals to the inpatient unit. And I tried to hide that anxiety, so I think hopefully I did. But I should point out that the staff was so appreciative of how you handled the study and how attentive and careful you were, and I think that's reflected in the very few number of serious adverse events that you had. And it's also relevant for the point you made about excluding suicidal individuals from randomized controlled trials, which is a real problem. And I think it demonstrates that with careful management and someone like you involved, it can be done. And the other point I think that's relevant, looking at it through that lens, is the differential effect of the ketamine on suicidal ideation versus depressive symptoms in general. Since we don't have suicidal individuals in many randomized controlled trials, we tend to generalize. When we're in the real world, we have lots of suicidal individuals, so we use the same treatments that we use that's based on evidence from controlled trials without suicidal individuals, and that may not be the right thing to be doing. So again, I think your study is important in that respect as well.
Oh, thanks. I appreciate that. And I think the small number of adverse events is also testimony to the great care that patients received on 5 South and 4 Center. And big debt of thanks goes to the staff of the units. And I totally agree about including suicidal patients in randomized trials, although definitely you need a large team and very careful, close follow-up to do that safely.
James had a question in the back.
Oh, I think Larry had a question, or?
Yeah, thanks, Mike, for that really great talk. So I did want to ask one question and follow up about those significant adverse events. You said there was a very small number. I didn't catch whether they were in the ketamine group or the midazolam group and what the nature of those events was.
I think I said there were 4 suicide attempts, none with serious medical injury, and 3 admissions for increased suicidal ideation during the follow-up phase. And we didn't, I think they were pretty evenly distributed between the groups. And as you recall, the vast majority of the midazolam group received an open ketamine infusion, since 35 of them, of the 40, were non-remitters. So during the follow-up period, 75 of the 80 had gotten a ketamine infusion. So it wouldn't be fair to really make judgments of the follow-up data based on the randomization group, I think. So I don't know, I hope that answers the question.
So one last question in the back.
So, Mike, my question is related to the New York Times article, which I was a little alarmed by. I guess this is my question. Given that your data showed that the average response was about a week, I'm specifically interested in treating someone in the emergency room with ketamine, because there was no discussion in that article about what might happen to those patients. And in fact, some of the doctors interviewed were actually emergency medicine attendings. They were not psychiatrists, at least not from what I understood.
Yeah.
So my concern specifically is you're going to someone will treat patients in an emergency room with ketamine. They'll have remission of their suicidal ideation transiently. They'll go out. They won't go into adequate follow-up. And then they're going to get more potentially suicidal again, etc. And isn't there risk associated with that?
Absolutely, and thanks for asking that question, James. That's a really great question, and I think it highlights some of the crucial gaps in knowledge and understanding of ketamine at this point, which is what do we make of this 1-week benefit, or even with a dozen or so infusions over a couple months. Those studies from Sanjay Matthews' group showed that patients tended to relapse a couple of weeks after that. So even that doesn't keep people well. And we all know that follow-up after emergency department visits tends to be not very good. So I think a study of emergency department use or just clinical use would have to incorporate clear follow-up plans and what the treatment plan would be and whether the patient had adequate supports and a provider in the community. So I think all those points are very well taken and really important to keep in mind.
Okay, I think we'll stop there. Thank you so much.
Thank you.
Wonderful talk.